Thank you. Good morning, everyone. You can hear me, right? It's fine. Hope everyone is having a good time at the partners. So I'll just go ahead and start the presentation on healthcare informatics. Before actually going to the agenda, I want to show you a slide. So when you see this different symbols like 26.2, it's a marathon. So whenever you are actually talking to your colleague or someone, if they actually go out, they say we are going to do yoga. And if you're at the grocery store, you feel like these symbols like USD organic. And there was other reports coming out of like Center for Disease Control and Prevention, like about the various diseases, viruses, and everything. And if you're online, sometimes you actually go and look for different health aspects, like how you prevent certain diseases or how you actually, look for different ways of identifying the diseases. So again, you see these symbols like when you're walking on this lift, they say take stairs for you. So all of these symbols, what exactly is behind? Can anyone say? What exactly is these symbols trying to communicate to us? Health. So all this is related to the health. So basically we are going to talk about health today. So coming to my agenda, I'm actually going to talk about healthcare informatics. Initially I'm going to define what healthcare informatics is, then talk about medical procedures, then talk about medical expenses, and our Blue Cross Blue Shield of North Carolina EDW program. And then actually the focus is on enterprise disease registry. So today's session major focus is actually how we implemented enterprise disease registry project. And at the end, I'm going to talk about the future trends. And due to the time limitation, I'm planning to keep the questions at the end of the session. So if you have any questions in between the sessions, please note that, and I'll take the questions at the end. So how do we define healthcare informatics? Healthcare informatics is a discipline where it actually has three different things that intersect. One is computer science, information science, and healthcare. So computer science basically deals with the resources, the hardware, and the different software programs we're actually using. Whereas the information science deals with the actual capturing of the data, organizing the data, and retrieval of the data. Whereas the healthcare part of the healthcare informatics deals with the clinical guidelines, medical procedures, or some clinical classification kind of information. So whenever we try to define healthcare informatics, it's the discipline which intersects computer science, information science, and healthcare. The next one is like, there are different names for healthcare informatics. It can be called as health informatics, medical informatics, nursing informatics, clinical informatics, biomedical informatics. So I was wondering why so many names, you know, they all look like the same. I mean, they mean same, but they're like small differences. So if you're sick, if you're going to a hospital, the first thing is that you are actually in the process, the data has been collected at different stages. So if you're going to a hospital, the first thing is they're asking for your insurance card. So they are actually looking at whether you have the insurance or not. The next thing is that if the hospital is doing any kind of services for you, they're actually capturing your details, like the inpatient details and what kind of procedures you have been gone through. And if you are taking any lab services, there is data being created in the lab services. And if you are going for prescription drugs, the pharmacy company, which is actually providing the drugs, is actually capturing your data too. So if you look at the different ways of capturing the data, we see that it's been captured at different points when the patient was entering to the hospital to the end where the care has been complete. So this data at different points can be named on different things. Example, like nursing informatics. Nursing informatics is where actually the nurses takes the information from the patients in terms of the prescriptions, the kind of procedures that they are doing for the patient. The next slide is about talking about the different medical procedures, like the most expensive medical procedures. So I have like a top 10 expensive medical procedures, and this has been published by Milliman. So let's skip bottom 5. So if you see the bottom one is around 153K just for the destruction of lesion of retina. And you see the tracheotomy, kidney transplant, pancreas transplant, and open heart surgery. They occupy the bottom 5 of top 10. And the next one is liver transplant, which costs around 523K. The next one is lung transplant, which costs 657K just for lung transplant. And the bone marrow transplant costs around 676K. And the heart transplant costs around 787K. And the winner in the $1 million club is intestine transplant. So just to transplant, like intestine transplant, which costs around $1 million. So why I'm trying to bring this slide is that to just give you an idea how sensitive the data is. Example, like Blue Cross Blue Shield of North Carolina has 3.4 million members. And at least 1,000 members having an intestine transplant is like paying $1 billion. And so you see the sensitivity there, like 3.4 million members and 1,000. So, so the next slide actually deals with talking about how the healthcare insurance industry companies as well as the members are on the same common motive. I mean, both the business as well as the customers are sharing the same business motive here. Because of the cost, the healthcare insurance providers usually say that I have to keep my members healthy, because that's how we can actually reduce the costs. Whereas the member wants to be healthy, he doesn't want to pay like, you know, whatever payments, like $1 million kind of thing. So he wants to be healthy, whereas the healthcare insurance provider wants to keep the costs lower, the medical expenses lower. So that's where we see both the healthcare insurance providers as well as healthcare policy members having the same motive of keeping the member healthy. Next, going to the Blue Cross Blue Shield NC EDW program. Blue Cross Blue Shield of North Carolina is the largest insurance company in North Carolina. And we have around 3.4 million members, and it's an independent licensee from the Blue Cross Blue Shield Association. EDW program, we started this in 2007. So coming to our data warehouse history, we have corporate data warehouse started in 1997. And it was initially an Oracle-based data warehouse. In 2003, we have converted Oracle data warehouse into Teradata. So the conversion happened in 2003. And our previous corporate data warehouse is a monthly load. And now the enterprise data warehouse, which we are constructing now, is a daily load. So far, we have, I mean, our enterprise data warehouse, if you look at our basic business strategy for a data warehouse, is actually to take care of member health. So our main core thing is to take care of improved health of our members and improved information and self-service, and supports technology simplification. So if you look, these are the subject areas which we are dealing in enterprise data warehouse, which is provider, member, product, enterprise disease registry, member contacts, claims, and producer. So far, we have done with provider, member, product, enterprise disease registry, and member contacts. These are all been in production, and as of now, we are working on claims and producer subject areas. Before talking, I also want to go through our basic warehouse design. We have a hybrid enterprise data warehouse design, which is like we have A, B, C, D layers. Our A layer is a transaction data layer, which is source. The B layer is the common data layer, where we land the sources. And our C layer is the warehouse integrated data layer. That's where we actually physicalize our tables in third normal form. And our D layer is a warehouse presentation data layer where we create the views utilizing the integration layer tables for the end user implementation. So the D layer is basically all views, and the C layer, which is the warehouse integrated data layer, is the tables, which are in third normal form. So if you look at the things which we have implemented so far, the provider, we have implemented the provider demographics, provider specialty, provider qualification, provider panel. We have implemented provider agreement, fee schedules, institutional pricing kind of things. In Member has gone into production in 2009, and we have implemented policy member demographics as well as policy member contact mechanism, how exactly we are contacting the policy member. And also we have done the individualization, the Trillium part, where if a member is coming at different times, like a member can come in 2003 and stay for the company till 2005, and he can leave. And he can come back around in 2007, and he can leave in 2008. So Trillium actually what it does is that it actually says this is the same person, and it assigns one person ID for the two individual members. So that we have done in the member subject area. The next one is product. This is quite complex area we have dealt with, because to just implement the product subject area, it took us some time just to figure out the actual implementation, because if you look at in a healthcare insurance product in terms of benefit packages or benefits, it's so complex to understand. So initially it took us some time to implement it, but now we kept that in the warehouse. Why I want to emphasize on member and product is that in the next slides, what we are going to discuss about the enterprise disease registry is actually going to utilize the member data as well as the product data. The next question is, what is disease registry? Disease registry is a database which holds the clinical data, which actually holds the information about the member diseases, or what exactly the medical test the member is going through, the patient is taking. So it actually takes us of the clinical data, medical tests, and organizes this information in an actual, in a good way. So a disease registry is a database which actually captures the clinical data, medical tests, and manages and organizes for the end users. Before further going into our implementation part of the disease registry, I want to take you through some facts about why exactly we need a disease registry. What is the basic business usage of a disease registry? Some of the facts is that so far around 130 million Americans live with chronic diseases, and the chronic diseases are usually heart diseases, respiratory diseases, mental diseases, cancer. Chronic diseases account for around 70% of all deaths in the US. And the cost, like the 75% of the nation's $2 trillion medical care costs are for chronic diseases, treating chronic diseases or preventing chronic diseases. So what exactly a disease registry does is actually to target these particular diseases, look at the medical expenses that are being spent on these diseases. So usually what happens is that if we don't have a disease registry, the diseases which are not chronic, they may take some of the major resources of the healthcare utilization. But if you have a disease registry, you can actually figure out where exactly the costs are going on, or where exactly the healthcare providers are spending in terms of treating the patients. And coming to the diabetes, like 2002 expenses were like around 132 billion to treat diabetes. And that's like 12% of the US medical budget and 25% of the Medicare budget. In the disease registry, diabetes is one of the conditions targeted by the registries because it's so prevalent. And usually they take care of the retina exams, the LDL levels, and the HbA1c levels. So these are basically captured. If a patient is going to for a checkup, if he takes up these retina exams, these LDL levels and HbA1c levels, and based upon these levels, the disease registry can actually say whether this person is prone to diabetes disease, or is there a chance of this person getting the diabetes disease. And the New York City actually implemented the HbA1c levels disease registry, which means they are actually capturing all the patients' HbA1c details of all the patients in New York City. And these are some of the recent findings with the International Diabetes Federation is that around 366 million people around the world are living with diabetes. And 4.6 million deaths happen because of the diabetes. And the healthcare spending on diabetes reached around $465 billion. So all these numbers, I'm just going to concentrate on next slides, how disease registry is going to try to get details of the actual diseases that the person is going on, and how we can actually reduce the costs by providing a good care to the patient. This is another survey which says who exactly are using the disease registry and what is the percentage that's been used by the physician organizations. So diabetes registries are utilized around 40.3%, whereas asthma 31.2%, congestive heart failure 34.8%, and depression 15.7%. So if you look, diabetes still ranks on top of utilizing the registries. And another recent finding about the World Economic Forum is the global impact of the 5 leading chronic diseases is around $46.7 trillion in the next 20 years. And the spread of those different 46.7 trillion is that if you look at this slide, this is especially for the non-communicable chronic diseases. And if you look at actually in this pie chart, you see that the mental health actually topped with $16.3 trillion loss of this chronic disease. This is in the next 20 years, from 2011 to 2030. So we have seen now in this slides, like what are the impact in terms of financially, like what happens if we see like these chronic diseases are so prevalent going on. So coming to this, I just want to explain you like what is the content in the disease registry that we are using. In the registry actually contains the Blue Cross Blue Shield of North Carolina, which we have designed this registry, actually contains the acute and chronic conditions. When this disease has been identified, like we usually maintain up to 7 years of history, 7+ years of history. Date most recently identified, the date that we have identified this particular disease with this person. And every month we are having the members was eligible with the Blue Cross Blue Shield or NC or not. So that data is usually coming from the product information and how the diseases were identified. What are the different sources we are utilizing to identify the diseases? What is the certainty measure that we are taking in? And what are the different rules that we are utilizing to identify the diseases? And also, as I mentioned, the certainty is another one important thing because we utilize different sources. And these different sources can say that this person has one disease and the other source can say this person has some other disease. So there is some certainty level assigned to each source. As I said, we have a 7+ years of longitudinal view of the member and what kind of diseases he's having. Enterprise Disease Registry is basically our single source of information where we go and access the data to just find out what diseases a particular member has from the last 7 years. So it's acting as a single source of disease information where we can capture in the disease registry. We have a rule-driven method where we use rules specific to each data source, ability to add new rules. Our design has taken into consideration adding new rules to the disease registry, and also allows multiple versions of the disease definitions. And especially now, we are actually capturing only 200 different diseases. So far, we are capturing only 200 different diseases in the disease registry. The next question comes, why 7 years of data? When we are capturing the history, why exactly we need 7 years of data? So coming to the analysis part, like whenever we are taking this data from the registry and doing some analysis, we do like the time series models. What's exactly happening to this person in a period of 5 years or 7 years? What exactly is happening with the one member? Is he having some diabetes, some other issues? Are there some comorbidities that's coming under diabetes or not? And also like modeling rare events. Modeling rare events is like where we see a high in certain diseases at certain period of time. So usually disease registry can trigger saying that this particular diseases are being very prevalent at this period of time, and we can actually look into them and say why exactly this particular disease is so prevalent at this particular period of time. And also the program evaluation. The program evaluation we'll be talking about in the next slides when we talk about healthcare programs. What exactly is a program evaluation? So the 7 years of data is utilized for time series models, modeling rare events, and the program evaluation. So this is one slide where I'm going to present about the actual sources that we have utilized to implement disease registry. The sources we have been utilized in disease registry as disease management vendor files. Disease management vendor files which we get is Accordant and Health Dialogue, who exactly does the disease management with the patient. And we also have the ETG. We have a couple of sites. We're actually going to talk about the ETG, what exactly ETG does. That is one of our source for the disease registry. ETG actually feeds 90% of the data into disease registry. We have claims. We have health risk assessment. Health risk assessment is basically about vendor surveys. When the patient comes and takes some survey, the patient actually says that he has this particular kind of disease in the surveys. So we use that health risk assessment. And MedVantage rules engine, which is care management. MedVantage rules engines is actually talks about the care gaps. If a person has a chronic disease, if he is not taking certain proper care, or if there is a gap between a particular test and another test, so there is a care gap. So that particular information is actually stored in MedVantage rules engine. And the next one is MaxMC. MaxMC is a system where we are using the care management. So if you look at this picture, these are the sources that are feeding our disease registry. And those sources we are actually taking through the ETL process, and our ETL process is actually holding those rules engine, like all the rules were taken care by the ETL. And we populate the and target tables. So if you look at this slide, this gives an example of some of the rows in the disease registry that we are utilizing. One is the first column, if you look, it's individual ID. Our individual ID is actually generated by the Trillium, as I mentioned before. It actually combines different members, saying this is the same member coming at different points. So we have the person ID, individual ID. We have the qualification certainty, at what certainty we are saying that this member has this disease. So that's like 100%. We have the disease code. Usually, I will talk about the disease code. We are actually talking about 3 different kinds of disease codes now, classification. The generic disease classification is ICD-9, whereas when we are utilizing ETG, we are actually using the ICD-9 in a different classification in ETGs. And we are also using CCS, another classification software, which is nothing but another classification of ICD-9 codes. So here we are utilizing the disease code, and we are actually talking about the disease description and the source which is coming from. We have a number for each source, which says the source is number 3. And the date first identified, when this disease has been first identified for this person. And the processing date is usually our technical date when exactly we process this row. And run date is also our technical way of saying when this particular row has been run. And we also have the rules, as I mentioned. So we have another table where we are actually managing the rules. By what rule we can say that this person has this disease. So that's the information we are actually providing here. So next slide, we're going to talk about some rules, how we define rules. So majority of the rules are coming from ETGs, episode treatment groupers. And as I said, our disease registry is actually holding whether a person has a chronic disease or an acute disease. So how do we figure out whether the person has a chronic disease? What are the rules that are utilized to say if a person has a chronic disease or not? If the ETG, the episode treatment grouper, says this person has a chronic disease, it's taken that it's chronic disease. That's one rule. And if a person has a 2+ professional E&M visits, evaluation and management visits, then it says he has a chronic disease. And if he has 1 inpatient admit and 1 ER visit, it says he has a chronic disease. Whereas the acute disease is just the ETG saying that it's an acute disease. So we just get that direct rule from the ETG. And for asthma and diabetes, our rules were actually from the prescription drugs. If the person is taking prescription drugs for asthma and diabetes, then we say that this person is having a chronic disease of this asthma and diabetes. And we also take the external data from vendor data and MaxMC surveys, which we talked. MaxMC is a care case management service where the member is telling that he has the disease, he has this particular disease. So these are certain rules that we are utilizing to say whether a person has a chronic disease or an acute disease when we are entering that into the disease registry. The next one is let's talk about ETGs. Before going to the ETGs, the next few slides talks about ETG. In the healthcare arena, classification of illness is very critical for analysis part or for reporting, the classification of illness of each patient or things. So if you look back, we used to have DRG. The DRGs are like DRGs usually is developed in Yale University in 1970s, and they usually take the inpatient data, DRGs. And later came the ETGs. The ETGs is a clinical software which groups based upon the claims, groups different data on the diseases and classify the illness. It actually creates an episode. So whenever a person is going for a new treatment, an episode is being created by ETG. So if the person is going for the treatment or the care again in the next 1 month or so, that will be added to the same episode. So ETG basically provides us a superior reporting and analysis of healthcare data, and it actually organizes claims data into a rational way of identifying the different illnesses based upon the differences in age, complicating conditions, comorbidities, and major surgeries. So coming to the comorbidities is like where you have other specific conditions other than the primary condition. So if you have a primary condition like diabetes, you can have a comorbidity, which is like an additional condition because of the diabetes. So it actually takes all this into consideration, and it groups and classifies, and it provides you the different episodes. That's what ETG is done. So ETGs actually give us episode treatment groups, ETGs, and episode risk groups. So episode risk group actually says which population is at major risk. For a particular kind of disease. So what population, subpopulation we have to this particular subpopulation is at risk for this kind of particular diseases. The ETG's advantage. So going to the ETGs, I want to say why we are talking about disease registries and ETGs at the same time. ETGs are basically episode-centric. That means if a person is going for a care for a particular new disease, he's getting an episode for that particular disease, and there will be an end for the episode. Whereas a disease registry is actually member-centric. So it actually takes the member, total view of the member from starting, from the last 7 years, and says what diseases he has from the last 7 years. But another thing is like, ETGs are like feeding our 90% data into our disease registries thing. So, so there's a kind of a difference between ETGs and disease registry. The advantages of ETGs is the network management, like the tiered specialty networks. So because of this illness classification, you can actually see how the providers are performing, how and what resources they are utilizing to treat the patients, how much they are spending on particular diseases. So you can actually tier the networks, provider networks based upon the ETG information. And the provider quality management, like the primary care, physician utilization, and urgent care facilities, how well they are being utilized. Because the claims data usually consists of all this information. When the person was admitted to the hospital, what kind of treatment he got, how much he has been charged. So usually the ETGs are actually processing all this claims information and trying to organize the information in a better way to get more details from the ETGs. So here the provider quality management also take care of cost efficiency of quality, and the utilization management is actually to identify how are the different services in a particular provider, either it's in hospital or a non-hospital, how are they being utilized? What are the different choices a provider is performing for the patient to pick for the treatment? And also it talks about the evaluate financial impact of policies. We have finance, which is identify drivers for medical cost trend, how much we are spending for each medical procedure over time. And the healthcare programs, it also gives us some information on market segmentation and program evaluation. So these are some of the benefits of ETGs. Recently, we actually converted from ETG version 6 to version 7. ETG is a product from Nginx, and version 7 actually adds more features with comorbid conditions. It actually has an ETG base condition status and comorbid conditions. And the volume of information that's been passed through the ETG has always been an issue. Why is that? Is that to run our ETG monthly, it takes around 6 days. Sending all the claims data into ETG and running those classifications takes around 6 days to get the results. And also the audience, like the end users who are utilizing these ETGs are the one who are deciding what is important. I mean, all the ETG sends a lot of information, so all the information is not utilized by the end users. They actually specifically pick, I need this information. I need to understand what are the risk groups I need to deal with. So there is certain kind of information that the ETG output has been used. This is also about the ETGs, like about the health conditions, symptoms ultimately drive vast majority of service utilization. So this slide actually talks more about the ETG, so we'll move into the next slide. So this slide actually talks about the different perspective that we are getting from ETG and disease registry. If you look on the right side, you see the most common comorbidities from diabetes episodes. So if there is a diabetes person, these are the other diseases, the other conditions that the person might have. So you see the number actually, like diabetic retinopathy or asthma. So these are somehow related to the person having diabetes. This is not the primary condition, but other conditions that are related to the diabetes. Whereas in disease registry, we are actually saying what is the cost, what is the total cost for diabetes. If you look, we have around 444 million just for diabetes, and how much we are actually spending in other comorbid conditions to treat the patients. So these are the different two views which we see. This is more like episode-centric, whereas we see in terms of the other one is more like member-centric, where we are identifying that the cost for the treatment of diabetes for a set of population. This slide actually deals with the role of ETGs in disease registry. As I mentioned before, 90% of our data in disease registry is coming out of ETGs. That is our major source. And we also utilize, why we are utilizing ETG as one of the major sources, that ETG software has most of the clinical knowledge, like how it does the classification kind of thing. So that's really helpful to us to feed the disease registry. The next one is what business information is available in our enterprise disease registry. The details that are available in our disease registry is the source, what sources we are getting this particular information, the rules, how we are actually trying to identify this person has this disease, and also we have the certainty, when this disease has been first identified. That is one major thing which we see in this slide. And when the disease has been last identified. So if the person has been coming with this diabetes in 2003, so the first identified disease would be in May 2003. So he's taking some other test or some other prescription in 2005. So that means he is still having that disease at that point of time. So we actually capture the last identified time at that point of time when he's coming to take some prescription drug. And it also gives how long the members had this particular diseases, and talks about whether the member actually has the product, he has the benefits with Blue Cross Blue Shield or not. So this is one business information that is provided by disease registry. And also we are actually capturing the age, gender, and benefits. I'll be showing in the next slide further more information. Coming to the chronic episode data, as I said before, we are using ICD-9 codes to identify the diseases. To say that a person has a heart disease or a respiratory disease, we assign an ICD-9 code to that particular person ID. Another way of classification we are also utilizing is clinical classification software. This CCS, what does it do is it's a hierarchical way of arranging the ICD-9 codes. This software is actually free, and it has 4 levels, which is a level 1, level 2, level 3. So at the level 1 is the highest level, where all the diseases can be grouped into 18 categories. Whereas the level 2, you can group them to 130 categories. Level 3 around 360, and level 4 is around 210. And this is actually updated annually, and it's free. And the good thing about this is that this particular CCS classification is utilized by the government organizations, by clinical research entities, and academic research entities. So utilizing this, we can share with other parties to understand what exactly is going on in this disease classification kind of thing. The next one, I'll give you an example where this is the CCS hierarchy for diseases of the respiratory system. So if you look at the level 1, it's at the highest level, which is 8, which is like combining all the respiratory diseases as 8. And you can actually subclassify into respiratory infections and a chronic obstructive pulmonary disease and bronchitis, asthma. And you can further classify those. So this is what the CCS does. CCS is actually classifying the disease course to identify what exactly this person had. So these are this is actually representing only 3 levels. So there is another further 1 more level. So this example is only showing at only 3 levels. This is an example where an ETG, the ETG codes are mapped to CCS codes. The ETG has a ETG base class number, which identifies the disease. Like example, 386800 in ETG is a congestive heart failure. Whereas the CCS code is 7.2.11, which is the third level of the CCS code, which maps to that. So we are actually mapping the ETG codes to the CCS hierarchy here in this. Let's talk about the end user views. So far, I'll just want to walk through what we have so far discussed. So initially, we discussed what healthcare informatics is. We actually saw what exactly disease registry is. We have seen some of the numbers like about the chronic diseases, what is the impact financially of treating chronic diseases. And we have actually dealt with enterprise data warehouse of Blue Cross Blue Shield. Then we moved to talking about actual design of the disease registry, and we talked about ETG, one of the sources of disease registry. And in this slide, I want to present our D-layer views, what end users are actually accessing, what kind of data they're actually getting from the disease registry. The first one is the member registry high cost claimant. So who exactly is the high cost claimant? Which members are consuming more amount of money for treating the diseases? So that view provides the high cost claimant for each person. So that's, that actually says person at disease level. And the next one is member disease detail aggregate all. So this is actually aggregating all the 4 levels of the CCS classification. So you're actually getting the 4th level, the top level of the CCS classification. Like in our previous example, you want to know how many people have respiratory diseases. So you can actually aggregate them and find that part in that view. You can actually find the highest level of the CCS classification. The next one is level 1, level 2, level 3 classifies. Those views actually produce the remaining classifications. And the major view in our disease registry is member disease detail. This member disease detail gives the entire picture of a person per disease, per rule, per month. So every month, if a person has a disease for a particular rule, that row will be there in this member disease detail view. So that is our one of the major views that the end users are utilizing. And the other view is member disease with always chronic rule. So once a member has a chronic disease, we always take that member has a chronic disease. So once a member comes into disease registry having a heart disease, he's forever chronic in the disease registry that he's having heart disease. So once it's a chronic, it's always a chronic. So that view actually provides all the chronic details of the members. And the final one is the member disease, which is like a base view. So all the views are constructed based upon the member disease. So these are the views we are actually giving access to the end users. And our end users are basically the power users, where they use directly access these views and write the analytical functions to actually get the reports. They are also utilizing SAS to run SAS on top of these views and just get the analytical results from the SAS. This picture is quite, this is one of the important table, what information we are capturing. We have the person ID, disease existent date, which is now. So this view is actually capturing per person, per disease, per month. So if we have from the 7 years, it's around 84 months. So each month for a person having a disease, that month data will be there. So this is a snapshot view. And we are having disease first identified date through date, and all the levels like the HCI or the CCS classification levels, the disease rule, what rule we are utilizing to say this person has this particular disease. We also bringing ETG base class code, HCI condition status code. Those are coming out of ETG. And one important information I want to point out here is that if you look the product information, Whenever the member is coming to Blue Cross Blue Shield, he can buy products in different ways. He can have a medical coverage, dental coverage, and he can't have the remaining coverages. So this particular view actually provides what coverages the member has. Does he have a medical coverage, dental coverage, chiropractic coverage, mental health coverage, substance abuse coverage, or vision benefits or not? So there are we usually provide 7 plan benefits. So this view actually captures whether the person has those benefits or not. We also capturing gender code, age number, birth date. The remaining are about the source as well as how we identified this particular disease. So this is one particular view where we are actually capturing all the related information about the disease, about the person. The technical details, coming to the technical details of the project, we have around 16 tables for this project. The total size as of now is 240 gigabyte. The Teradata version that we are using is 12, and total sources were 6 sources. And the ETL tool that we are utilizing is Ab initio co-op version 3.0.3.6, and the PC SAS 9.2 and SAS Enterprise Guide 4.2. And another important thing is that the member disease detail table, as of now, we are having 172 million rows. So coming to this big data, we have some issues like in terms of performance. So as I said, initially in our hybrid warehouse design, we give access to the end users only to the views. So when we constructed view on top of this detailed table, so it took almost it's almost less than an hour to run the particular query. So the users can't wait that time to just run around this particular, because our D layer, our presentation layer actually utilizes joins to combine different tables. So when we are utilizing these joins to combine different tables, then there is a performance issues. So how we resolve these performance issues, I'll show you. We have a flow chart of resolving these performance issues of this big data. The next one. This is more for the technical folks, how we resolved the performance issues because of the large volume of data. Because we have 3.4 million members. 3.4 million members, if each one has a disease, and every month he has to capture that disease and what kind of different diseases he has. So you see the kind of data we are dealing with. So this flow chart says we have an SLA. So from the end users, we say that this particular query has to be done at this particular point of time. I mean, we need to get the results within 1 minute or 30 seconds kind of thing. So we have an SLA from the business users when we are collecting the business requirements. If the views are not performing, the first thing we do is we tune the views. We change the views and everything. If that's also not performing based upon the SLA, we see that we apply indexing strategies to the base tables, which are in the C layer. So we do some apply indexing strategy for the C layer tables. If that's also not meeting the SLAs, then we usually review the design of the integration layer to see whether it's a completely third normal form or not. And we try to make the change. And if the views are performing well, we stop there. I mean, that has met the SLA. But if still that's not working, the final option we usually take care is to physicalize the view structure, which is materialization. So for our disease registry project, we actually materialized 2 views because of the performance issues. And after materialization too, if the SLAs are not met, I mean, if the business is not happy about the performance, one thing is actually go and talk to them and say, can we negotiate the SLA or add more Teradata hardware? So this is how we are actually doing in terms of performance of views. So the next slide is about the uses, the enterprise disease registry uses. One is program planning, utilization management, medical cost trend analysis. what is program planning? You know, healthcare programs. We also have healthcare programs. Healthcare programs are like going to the member and talking to the member and giving him information to keep him healthy. So it's basically a proactive way of talking to the member and telling him to live, to change the lifestyle for better health outcomes. So we have different healthcare programs. We have around 11 to 12 different healthcare programs which talk to the member, which sends brochures for them and talks about like going to a workout or joining some other clubs, health clubs, to keep them healthy. The utilization management is about how well the providers are being utilized, how well the provider resources are being utilized. So the utilization management deals with a particular, it can be in a hospital or a non-hospital. It can be a lab service or pharmacy services. So it talks about that. And also we also have the program evaluation. So as we said, we have around 11 to 12 different healthcare programs. The data from the disease registry helps us to say that are these programs working or not for the members. These healthcare programs are working for the members in a better way, or we can improve the programs or not. And also we are utilizing in segmentation for health programs, also giving member clinical view for nurses. And also we are also providing this information for, not yet, but in the future we are planning to share this data with providers, the disease registry data with providers. So the two things which I want to talk about in the programs is disease management and case management. And disease management is basically you're trying to target a particular disease like diabetes and target a subpopulation and send them the brochures or the information about curing the disease. Whereas the case management, you assign a case manager to a particular person and try to provide more information to that person in terms of prescription drugs or the tests kind of things. So these two are the important things that are being taken care of utilizing the output from the disease registry. This is one slide where it actually talks about how disease management programs are really helping to cut down the costs. So this is from a Congressional Budget Office. So this is another important slide. Initially, the present trend is that we have CHF, which is like a congestive heart failure, which is taken as a chronic disease. Now, as of now, we are actually trying to deal with the clinical factors of how exactly we can avoid congestive heart failure. But the future trend is to look after the patient and try to change his behavior to see that he doesn't get that particular disease. How we can change the behavior of the patient, of the member, to make sure that he is having a healthy lifestyle, not to get this kind of chronic diseases. So as of now, we are actually dealing with clinical risk factors. The future trends is basically is to integrate this particular data with specialist expertise and primary care, provide timely reminders to providers as well as patients, identify subpopulations for care. So it's basically, in the future, it's about connecting all the different entities in the healthcare organization. It can be providers, it can be pharmacy benefit manager, or it can be lab services. So it's connecting all these entities to provide a holistic view of the member and his health. So this is what I'm talking about providing the holistic view of the member, which is the view about the integrated health management, where contacting the physicians, contacting the disease management programs, contacting the member. So it's all combining the data and providing one view of the patient, just one view of the member, what exactly it's going through the member kind of thing. So the summary of this presentation, I think, is about how exactly we have moved from episode-centric ETG to a member-centric way of dealing with the diseases. So And also, as I said, the ETGs has to be run monthly. So monthly, we took around 6 days to run the ETG. Because of this registry project, we are able to go and get the disease information from the enterprise disease registry without running ETG again and again. So the thing is, like, ETGs are the primary engine for the registry, but the registries offer flexibility to handle other data sources and changing business needs. So, any questions? Yeah.
Do you use this as best practices, define best practices? So, for example, you see this provider and he gets train wrecks, but over time they're not train wrecks, and then share what he's doing with other providers.
I think that's not happening yet. Actually, one provider sharing another, especially if he has to get the permission from the member. Right? I mean, if you have your health records with one provider, the first thing is they have to ask you, the patient, whether I can transfer the records to other provider or not.
Well, you wouldn't have to have the member involved at all, but you could just tell from looking at risk factors and stuff that over time this provider really heals and the risk factor goes down, where other providers, it gets the risk score keeps going up and up and up.
As of now, we are not sharing kind of health information to all the providers as of now, actually. So, yeah. Any more questions?
Any other questions?
ETGs and DRGs and R grouping software is great, but I was wondering if y'all tried to really integrate anything like lifestyle data that you can go out and buy, like what magazines people subscribe to or things like that, to really give indications of how healthy a person might be?
Like the surveys we are capturing, the surveys, that's where we are actually sending a survey to the member and asking about his health conditions, what he exactly is doing. Is he eating healthy vegetables, fruits kind of thing, or how often he goes to do some workout kind of thing. So
yeah, or like what magazines they buy, or if you can really get an idea on some of their credit ratings, if they're really going out and eating and you see them using that credit card at fast food restaurants a whole lot, and you say, this
no.
person's going to get the McDonald's disease or something like that.
No, we are not actually capturing that information yet, but maybe in the future. Yeah.
All right, thanks everyone. Please be sure to fill out your surveys. Let's give Siva a hand.
Thank you, guys. Thank you.
Tough being right before lunch.